Good evening, everyone, and welcome to the Johnson Shoyama Graduate School of Public Policy's fourth annual Houston Lecture, Learning from the Pandemic, Challenges and Opportunities for Healthcare System, featuring Dr. Katharine Smart, President of the Canadian Medical Association and a pediatrician in Whitehorse, Yukon. My name is Jennifer Oshoey, and I am a student at the JSGS in the Master of Health Administration stream, and I work as a pharmacist at the Winnipeg Regional Health Authority. I'm honored to be your MC for tonight's Houston Lecture. My MHA studies with JSGS have provided context to the disparity in health status and healthcare provision I have seen through my work, and have also highlighted the importance of prioritizing policy decisions that will meaningfully impact the health of Canadians. As Dr. Smart is such a vibrant leader who is committed to engaging the community and government partners in pursuit of their common goals, I am very excited to learn from her experiences in and vision for healthcare this evening. I would like to acknowledge that while tonight's event is taking place online, JSJS's physical home is located on the Treaty 4 and Treaty 6 territories, the original lands of the Cree, Ojibwe, Saulteaux, Dakota, Lakota, and Nakota, and the traditional homeland of the Métis. I am joining from my home territory on Treaty 1, the traditional lands of the Anishinaabe, Ojibwe, Innu Cree, Oji Cree, Dene, and Dakota, and is also the birthplace of the Métis Nation and the heart of the Métis homeland. And tonight's speaker is joining us from the traditional territory of the Kwanlon-Dun First Nation and the Tahan Quachan Council. We pay our respects to the First Nations, Métis, and Inuit ancestors of these places, and reaffirm our relationship with one another. We are glad to welcome those of you joining us today from across Turtle Island, and make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting. Knowing that we have people visiting and joining us from across the country, I would be remiss if I didn't say a few words about our school. The Johnson Shoyama Graduate School of Public Policy, or JSGS, is a national hub for advanced study and research in public policy and administration, with campuses at both the University of Saskatchewan and the University of Regina. JSJS's graduate and executive development programs build knowledge, skills, and competencies for success in government, nonprofits, cooperatives, and credit unions. Nationally recognized for our professional training and research excellence, JSJS is responding to the needs of the public sector partners, including First Nation, Métis, and Inuit organizations, governments, and communities who are confronting economic, social, and environmental issues. One research area that speaks to me, and likely many of you joining us, is the school's focus on social policy and inequality, and more specifically, health policy. Through events like the Houston Lecture Series, JSGS is able to bring together thought leaders, academics, students, and community members to listen and learn about the current issues affecting Canadians. Before I turn it over to JSGS's Executive Director, Dr. Laline Berdal, I would like to take care of a few housekeeping items that will help our event run smoothly. We kindly ask that all attendees stay muted and turn off their video during the presentation part of the event, but feel free to put your video back on when we get to the Q&A. If there's any logistical issues during tonight's presentation, please don't hesitate to send a message to Karen Jaster-LaForge via the Zoom chat function, or email her at jsgs.events@uregina.ca. Karen has posted her contact information in the chat. The format for tonight's event is as follows. Following the opening remarks of our speaker, Dr. Katharine Smart, and tonight's moderator and JSGS Executive in Residence, Dan Flores-Lazone, will engage in an armchair discussion for approximately 40 minutes. For roughly 30 minutes following her presentation, Dr. Smart will entertain questions from the audience. If you'd like to ask a question, please use the Zoom chat function at any point and submit your questions directly to Dan Flores-Lazone. Because we have a large audience, which is wonderful, please keep your responses concise and to the point, as we are short on time and we would like our speaker to be able to answer as many of those questions as possible. Feel free to submit your questions at any time, again, to Dan Flores-Lazone. With that, I would like to welcome Dr. Laline Berdal to provide a few welcome remarks.
Well, thank you, Jennifer, and thank you everyone for being here. On behalf of JSGS, I would like to welcome and thank you all for attending what promises to be an engaging and thought-provoking evening. Tonight, we are fortunate to have a number of individuals joining us online, including, and of particular note, Dr. Stan Houston and his son, Adam Houston. They are the family of Dr. Stewart and Mary Houston, and the Houston Lecture Series would not be possible without the generosity and support of the late Dr. Stewart and Mary Houston and the Houston Family Trust. Both Stewart and Mary were greatly loved at the University of Saskatchewan for their genuine enthusiasm in supporting research and dialogue on campus. Widely known and respected for their love of ornithology, Stewart was also highly regarded for his distinguished medical career, specifically in diagnostic radiology. Interested in both medicine and Saskatchewan history, Stewart published extensively on the history of Medicare and Saskatchewan's early achievements in healthcare. An early campaigner and defender of Medicare, Stewart developed an insight into the intersection of politics and health, the critical importance of the social determinants of health, and the vital need for public policies impacting health to be based on the best possible evidence. That is why both he and Mary were so keen to support JSGS in facilitating dialogue and creating opportunities for evidence-based research in areas of health, social justice, and income inequality in Canada. As part of their generous donation, the school launched the annual Houston Lecture Series in 2018 in their honor. Since then, we have welcomed a number of influential speakers to share their insight and are so fortunate to add Dr. Katharine Smart, President of the Canadian Medical Association, to this growing list. With that, I'd like to turn the floor over to Dan Florazone to introduce our keynote speaker. Dan?
Well, thank you so much, Lillian. Really appreciate this. And we're absolutely looking forward to tonight. The real treat is having Dr. Katharine Smart with us. And for those of you that haven't had the privilege, she has been engaging. She's been out there throughout this pandemic, throughout her period of the work with the CMA as president. I've got to say how impressed I have been with the presence and the leadership that she's shown. So as the president of the Canadian Medical Association, Katharine is the 10th woman to hold this role in 154 years. She works also as a pediatrician in Whitehorse in the Yukon. Now, one of the greatest attributes that Katharine has is she's originally from Swift Current. So that's something that we need to celebrate. And she'll always be from here, no matter where she ends up, wherever she goes. Her work is centered on developing collaborative partnerships with community and government services to serve marginalized children using a model of social pediatrics. And we're really eager to hear more about this. She works primarily with children who've experienced trauma and adverse childhood events, and witnesses the broad and lasting impact these events have on children and their development daily. She's passionate about improving services for marginalized children in an effort to change their life trajectory. In addition to her community-based work, Dr. Smart enjoys acute care and provides on-call services to the hospital. Before moving to the Yukon, she was a pediatric emergency medicine physician at Alberta's Children's Hospital in Calgary. She's also the past president of the Yukon Medical Association. And I know in addition to a broad-based audience that we have here today from Saskatchewan and across Canada, your friends from Yukon are also here to cheer you on, which is always great to see. So I think we're in for an engaging evening as she provides us with her thoughts, her wisdom, her experience on how the healthcare system can learn from the COVID pandemic and how we can move forward from where we're at today to what we ultimately can be. So Katharine, Dr. Smart, welcome. We just have to get you off of mute.
Oh, thank you.
No worries. You're new to this technology.
I am. It's my first time on Zoom. But yes,
Thank
thank you so much. Well, and thank you for the kind introduction. I really appreciate that. And it's a real honor to be featured in an event in Saskatchewan, where I grew up, where my parents still live, and so inspired by the work you and your team are doing in Regina and Saskatoon, and that next generation of leaders in our healthcare system. And we're going to need all of them with the changes that are needed. So it's great to be able to share some conversation with you all tonight.
Thank you for taking your time. Thank you for spending this time with us. So tell me a bit about, well, maybe let's start with where did we catch you today? We're having an armchair discussion, but your chair is situated where?
I'm actually in Ottawa this week. And that would actually, like many things in this role, sort of came up last minute. There were some opportunities to meet with different levels of government here and different politicians to advance some of the ideas that we have around the healthcare system. So that's why I have this nice fancy chair, because I'm actually in a hotel. And I thought it was appropriate since we're having an armchair conversation about healthcare. So worked out.
I feel like I should be in a chair next to you, beside you.
I know.
Interacting maybe on the same screen, but we'll put up with this. I wanted to ask you about this journey. You know, it's always fascinating for us, you being always from here. How does a young, aspiring woman in Swift Current go to and be on this journey to go up north? I mean, that's a major step. To bring your leadership to the Yukon, to Whitehorse, such a beautiful place, beautiful scenery, and such immense opportunities and needs to be met. And then to be thrust into the position of president of the Canadian Medical Association. Congratulations, but could you talk a bit about that journey?
Yeah, for sure. And I think my parents are actually joining this lecture tonight from near Swift Current at the Saskatchewan Landing. So they could give you insights into what I was like to deal with as a young person. But I think what they would...
I noticed Marilyn's name, and I was going to ask you, is Marilyn your mother? That is,
yeah, Marilyn and Jim.
Excellent. So I do see that they've joined us.
Okay, wonderful.
Congratulate them before this meeting's over.
Yeah, well, I think what they would tell you is, and I think why I would say I sort of find myself here today is curiosity. I think has always sort of been in my nature, and it was actually my dad's grandfather, so Jim Smart, a few generations ago, who actually came to Canada as a settler and settled near Saskatchewan along the river there, ranching. And he was an explorer, traveled all around Canada, went to South Africa. It was a real spirit of adventure, and I think I sort of inherited that from him. So growing up in Swift Current, I always just remember being so curious about everything else outside of Swift Current and what else was going on in the world, all the places I could maybe go. I had a world map in my bedroom as a teenager, and I remember, looking at it and sort of dreaming about what my adventures would be. And in my family, my mom was a teacher, my dad ran a small business in Swift Current, and they were both really involved in the community. And I think always spoke to myself and my younger sister, who's actually a nurse, so we both ended up in healthcare, always a lot about this idea of service and the importance of doing things for others. And one of the things my dad always told me growing up was that you're always happiest when you're doing something for someone else. And that always really resonated with me. So I think as I went through sort of my educational experience, decided to choose medicine, it was because of that interest in, hey, this is an exciting career. There's lots of things you could do. And also deeply rooted in that family value of service and the opportunity to do things for other people. So that led me to pediatrics, which I really went into medicine thinking I was interested in children and their health, and ended up training in that. And through my training in pediatrics, I think I really started to get a different sense of other communities, other issues, things I had maybe not really been exposed to in my childhood in Swift Current, but my eyes, I think, were really open to some of these broader societal issues, social determinants of health, issues of privilege, why some of us have things and other people don't, in a new level of awareness. And for me, that my interest in the North started as a pediatric resident. I had the opportunity to spend a month in Nunavut providing services there. And this was before there was pediatricians in that territory. So I was there for a month and really, became enthralled just with the health issues in Northern Canada, the issues facing First Nations, Indigenous, Métis, and Inuit in Canada, and was really drawn to that. And from there, I started doing some locum work in northern Manitoba with similar challenges. And I also had some opportunity to work overseas in my training in South Africa, in Uganda, in Laos, in Southeast Asia. And all of those things, I think, really made me interested in sort of those deeper questions of why are some people healthy and other people aren't, you know, how equity, what is happening there. I also really liked acute medicine. So I did end up doing emergency medicine, and I practiced at the Children's Hospital, as you said, for many years. But what I remember, you know, as I went on in that career, I loved that work. Of course, working in a children's hospital is an incredible place to be, because the people that do that type of work are passionate about children. There's a real sense of a collective vision of where you're going and a real sense of excellence. And I loved being in that environment. And I was very fortunate to be trained and mentored by many amazing clinicians across the health professions in that job. But what was always interesting to me was that issue of, you know, okay, how can I dig deeper into some of these things I really feel passionate about? And throughout my time as an emergency physician, I had kept working in Northern Canada in more of a locum role. And one of the things that always frustrated me was I felt that in that role, I was never really able to work with the community to address some of these root cause issues. So that was always sort of at play in my mind. And then this opportunity came up. I actually went to Whitehorse. I was invited there to teach a course at the hospital on neonatology. And while I was there, just getting to know the family doctors in the community, the people in the hospital, again, there was this real sense of dedication to the community, this real desire to provide excellent medical care. And I felt really, you know, inspired by the people there, and talking to them, it was pretty clear that they were looking perhaps for more support around pediatrics. And I knew some of the pediatricians that were working there as visiting specialists at the time. And speaking with them, it was also clear from their experience that they felt they were kind of just hitting the tip of the iceberg in terms of what the issues were for children in the territory. So I thought, you know what, maybe this is sort of the space for me. I can combine this passion I've had for rural and remote medicine. You know, I'm bringing this emergency skill set, which is good, of course, when things aren't going well for kids. But I also have this desire to kind of dig into some of the deeper pieces. I was interested in getting more involved in mental health, because one of my frustrations in Emerge was seeing all these kids who were often falling through the cracks, but not really having a mechanism to do more to support them. And that came together with the vision of the social pediatrics program that we now have in the territory. And I think it was, for me, a really good time in my career, because I brought a lot of lived experience in medicine, a lot of, you know, what was working in the systems I'd seen, what wasn't. And because it was a bit of a blank slate, it really was an opportunity to sort of imagine, if you wanted to provide healthcare, how would you do it in your ideal way? And I basically wrote that up and connected with the government around it. And they, in a lot of ways, did give me carte blanche to sort of develop that program. And that's what we've done. And then from there, you know, how did that turn into medical politics? Well, some of that was, I think, a little bit of circumstance. I like to say I was voluntold into being the YMA president. That was not necessarily a highly competitive opportunity, but it was, you know, it's a small group of physicians, and there's always that need for people to take on some of these roles. And you know, I guess because I like talking, people thought I'd be good at it. So I ended up doing that. And through that opportunity, I actually was then more involved with the CMA, because when you're involved at that provincial territorial level, you participate in these various national events as well. And I got more interested in what the CMA was doing and their work. And people may not know this, but the presidency of the CMA rotates around the country to give, you know, opportunity for that different representation from different parts of the country. And it, you know, it just happened that the Yukon's turn was coming up. So I sort of, you know, I had to really reflect on that. It's a large role. It is a full-time job. Normally, pre-pandemic times, it involves a lot of travel. That's obviously been slightly less because of the pandemic. But I really felt like it was something that I felt, you know, was an amazing opportunity to really dig into what my passion in medicine is. And I would say for me, my deep passion is really around advocacy and trying to create change in the system. And I thought, you know, what better platform to really do that than having this national platform to really work, you know, of course, not alone, but with partners, learn from people, work together to really try to understand how can we move the needle on this healthcare system that means so much to us as Canadians. And so I put my name in for the election, and I ended up winning. And ironically, I found out I won the election literally about 3 weeks before the pandemic was announced. So it's all been very different than perhaps what I was anticipating at that time. The first year I was the president-elect was in the first year of the pandemic, and now, of course, I'm in the role of president. But I've been, really grateful for this opportunity to try to do what I can in a very difficult time, to work at an organization like the CMA, which I think is really working hard to try to bring forward ideas around how do we reimagine this system that we find ourselves in. And it's been an incredible opportunity to meet colleagues such as yourself and other amazing physicians in Saskatchewan, and just see, that deep passion for service, for healthcare, for patients, for Canadians that so many physicians in this country share, and to be able to represent them on the national stage and use the voice that CMA has to try to advocate for that change has been very rewarding. So I think I was a curious little kid in Swift Current with a great family that sort of pointed me in the right direction, with some genetics hanging on from that pioneer great grandpa, and here I am.
Well, cool story. I mean, that's really inspiring, and it's the kind of story that everyone needs to hear in Saskatchewan. Now, there are 3 positions of president at the CMA. One is the president-elect, then the president, yes, which you are, and then the past president. We have this great privilege in Saskatchewan of having 2 of those out of 3 from here. So Lika LaFontaine is
that's right,
actually from Regina, which is great. Now, I didn't set this up, but look at the book I have.
Oh, there you go.
Yeah, so it's actually written by Greg Marshallton, and Greg is a father of the School of Public Policy here in Saskatchewan. So I'm trying to create everything as a connection back to Saskatchewan, because somehow it all started here.
Well, that's what I always said when I was in university. We had a little group at UBC called the Wheat Pool Posse, and we definitely claimed that everyone ultimately was from Saskatchewan if you look deep and hard enough at their past.
So I want to talk to you about your timing. I mean, could it be better? You come in almost on the eve of your election, pandemic. You've been thrust into the spotlight. Practitioners, I mean, we started in early days of pandemic with banging pots and celebrating all things healthcare providers for the heroism of what they were doing. And now it feels like it's been dragged. And sometimes we've got a health provider group that's feeling a bit demoralized, maybe feeling a bit beaten down. Maybe it's the advice we've given that hasn't necessarily been received, or a feeling like somehow the healthcare system is at issue or at fault. You've been the voice of reason. You've been out there and really inspiring providers. Tell me a bit about what difference or what pivot or change you've needed to make, not only as the president, but as the medical association.
Yeah, great question. And I absolutely agree with you. The pandemic has just been so challenging in so many ways. And I think for everyone, I mean, who hasn't been touched by it? And I think as healthcare providers trying to navigate it, and you're right, as an organization, trying to navigate the pandemic in a rational way, but still a passionate way, still trying to bring your voice, but trying to balance these things out has been, I think at times, really difficult. I think I came into the president role sort of halfway into the pandemic. I think the first part of the pandemic, there was, I would say, a lot more alignment, right? Like when we first all locked down and there was this new virus and everyone was afraid there, our biggest concern at that point was, where do we find the PPE, these very practical things? Are we all going to die? Are we going to live? What are we going to do? And I think there was this, like you say, sense of urgency that kind of brought people together. And there was this sense we're all moving in the same direction. And by that, I mean our governments, our health leaders, our healthcare providers on the front lines, and our communities that we serve. And then I think as we got deeper into it, it started to get a lot more complicated, and we started to see a lot more politics coming into play in terms of decision-making around health. We started to see ideology come into play, perhaps more than science. Of course, there started to be disagreement over what the science was. And then I think, we had this miraculous advent of the vaccines, which have been incredible in saving lives. But then all of a sudden we had the challenge of how do we get people vaccinated? Initially the rush, the urgency to get vaccinated. But once we got through those first people that were first in line, all of a sudden we realized there's not as many people in the line as we need in the line. Like, we've got to do better than this. And that started to become challenging. And then our ethical obligations as healthcare professionals, the CMA was one of the first ones out saying that we felt vaccines should be mandatory in the healthcare setting, that we had to prioritize the health of our patients and really create a safe space where people could know their providers were vaccinated. So that was, quite a bold thing at the time. And of course, not everyone agreed with that, but we saw eventually that really come into play across the country. Then the next big conversation was around vaccine passports. And was this a good idea? And again, we were out saying, like, yes, this makes sense. We need to do things to move the population towards being vaccinated, because it's so critical for their survival. And it's also so critical to protect the healthcare system and the vulnerable people in our population who are at risk. So again, there was a lot of advocacy there, and again, a lot of controversy. Understandably, these are big things, but we again saw that sort of roll out across the province. And then I think we started to see, all the public health protections that we were all simultaneously learning about. And initially, again, I think a lot of alignment about what those were and the importance of them. And then we started seeing different provinces and different governments sort of fragment away from what I think a lot of frontline people felt was important, and just huge pressures on our hospital caring for patients that were critically ill, and also huge pressures on our hospitals and on our community-based physicians about what about everybody else. And I think that was really deeply challenging. And I think when I really started, I think, to see healthcare workers start to feel demoralized is when they were there, just fighting on the front lines of this, caring for all these patients, and started to feel their governments maybe stepping away from that reality and communicating different things to the public, and not maybe representing what they were seeing and living in their work day to day. And what was so interesting about that, I think, is how much you saw physicians try to step in and fill that void of information to really make sure that Canadians knew what was going on and how serious this was, and what these things meant, right? Because again, I think it's like anything, when you're inside the tent and you use certain language and you talk about certain things, it means one thing, and it doesn't necessarily mean the same to someone outside the tent. So, an example would be when we have government saying, like, oh, we've added 90 new ICU beds, and you're a doctor going, well, yeah, it's a bed, there's no nurse, there's no monitor, or, we pulled the nurse from the dialysis program and now she's an ICU nurse. Like, this is not an ICU bed, right? So it was things like that, I think, where there was a desire to sort of present one thing to the public, and that lived experience of the people on the front lines was really something very different. And they were deeply concerned that what the public was being told in terms of what they could expect or the type of care was not in alignment with what they could deliver. And I think you really got this sense of they just had this desperate desire for people to understand that and understand the importance of these public health protections in the community level to protect that critical resource of the healthcare system. And again, I think, like in so many things, what was also so powerful is what started coming out is, COVID is not the same for everyone. Our marginalized populations are disproportionately impacted. It is racialized communities. It's people working in congregate workplaces, in factories, in grocery stores. These are the people that are getting sick. They live often in overcrowded housing, whole families coming into hospital. And again, this was another thing we started hearing doctors talk about: paid sick leave. This is of critical importance because we can't have people having to go to work when they're sick and spreading COVID to everyone just so they can put food on their table. And again, I think as physicians, we've always been advocates around things like social determinants and the social fabric of our society. But I think you saw it elevate to a whole nother level because it was becoming such a critical factor in how this pandemic was playing out, on who was being impacted and what that looked like. And just the importance of understanding the differences, that this disease is not impacting everyone the same. I think for myself, we locked down, I pivoted my clinical work to virtual and I was able to keep going. But, the person bagging the groceries at the local grocery store didn't have that option. Right. So, it really was different for different people. So I think you really saw this advocacy on a different level. It was very public. You saw a lot of physicians stepping into the media, into social media, traditional media, just really trying to get that story out there. But I think, the emotion at the heart of it, as we got deeper into this, I think was often a feeling of abandonment. Where are our leaders, and are they hearing us? Are they supporting us? Or are they, you might have heard me use the word gaslighting a few times at the peak of things, when we really felt that we had to call out as an organization what was going on, right? Like, we're hearing one thing from our political leaders, and the reality is really something truly different. And we have to name that so that people really understand how serious this is. So I think it was interesting for the organization, because like many big organizations, I think, the CMA tends to be more on the conservative side traditionally. And I think this experience pushed the organization more to really decide, if we're saying we're advocates, if we're saying we're speaking for Canadian physicians and we want to protect the public and we want to serve patients, we've got to step into this arena and have some of these difficult conversations and question some of these things, because it's, number one, this is not an experience really anyone had been through before in modern times. So it's hard to know exactly what to do. But also, we are hearing from our members what they feel is really happening, and they need someone to bring that voice loudly and make sure that they're being heard. So I think we really thrust a level of attention on our profession and the organization. I think that was different than what there'd been in the past. And then, of course, then the other issue is, as all this was going on, there was all the other health impacts that were important as well. We, did one of the first studies looking at backlogs, at the beginning of the pandemic. Wow, hundreds of thousands of people haven't had their care. Our first estimate was at least $1.3 billion to catch that up on only 6 procedures. We knew that was, again, just the tip of the iceberg. Later on in the pandemic, we did another study where we were able to look at other impacts, worsening mental health in a 5-month period, 4,000 excess deaths not related to COVID in our population, likely from not being able to access care. So if you extrapolate that over the pandemic, at least 20,000 Canadians have died because they couldn't access healthcare because of these lockdowns.
We also talked just before this session about the opioid crisis.
Yes.
If you wanted to just say a few words there.
Yes, absolutely. And I was going to say that next. That was the other thing we found in that same report, was 20 people a day losing their lives to opioids. So, this was a profound parallel issue around people's health that wasn't maybe getting the same amount of press because naturally we're focused on COVID, but at the same time, so much suffering. And when you think about burnout, and why I think we're now seeing these really record levels of burnout for healthcare professionals, almost doubled since the beginning of the pandemic from work that we've done at the CMA. I think it is really that moral injury from working in this broken system and not being able to get people the care that they needed. So I think of our family doctors in our communities, having to pivot to virtual care. How do I reach my patients? How do I make sure people get what they need? And then having to be there with patients as their surgeries keep being canceled, as they can't access care for their mental health, as they're dealing with their substance disorder, as they're in chronic pain, as they can't see the specialist, and there they are having to hold all that for the community without really being able to do anything about it. The surgeons who are worried about their patients, who are in pain, suffering, their cancer's getting worse, they can't get them into the OR. That's where the burnout comes from, because you feel hopeless about your ability to actually help patients, which is why you were there in the first place. And then I think when you hear, right now, even where we find, the pandemic's over. Well, no, it's not. And, it really, I think that discordance between what people's lived experiences, what they're seeing, the suffering they're dealing with, and this sort of desire to normalize or minimize it, I think has left a lot of people, a lot of medical professionals in medicine and in our other health professions, really feeling like, do people understand what's actually happening here? So it's been a really, I think, challenging time to navigate all these things, to try to bring them to the attention of the public. But also, I think the positive is we're all talking about these things now. I don't think the Canadian public has ever been as aware as they are today about how deep these problems run in the health system. Because to be clear, they were there before the pandemic. This is not all new. It's just been put under pressure and exposed more. But I think there's no one right now in the country who's not aware of this human health resource crisis, of the need for health system innovation, of these profound other impacts on Canadians, things like the opioid crisis, the mental health crisis in long-term care, home care, just how many things aren't part of universal health care. Because again, that's a bit of a misnomer in this country. When we talk about universal health care, it's not what people think it is. So I think this is an opportunity to really step back and say, okay, we want to come out of this pandemic. What do we want that to look like? It's got to be more than just going back to the status quo. We have to reimagine the system.
Yeah, can I pursue that a bit? And that is, it would be a real shame for us to walk away from this pandemic and do what we usually do, which the tendency is to say, whoa, that's over. Now let's keep going. There's this opportunity to collect what's worked well and what hasn't. What have been our learnings. So could you reflect just a bit on that? And you've covered quite a few, but some of the positive things that have come out of the crisis.
Yeah, for sure. And I absolutely agree. And I think that's exactly it, is what has worked, where can we learn, and what can we amplify as we move forward. So I think one of the really fascinating things about the pandemic and what's really impressive is that dramatic pivot to virtual care. Literally overnight, thousands of healthcare professionals pivoted the way they reached their patients at a level we'd never seen before, which is actually incredible when you think about, the amount of change management that would normally have to go into something like that. And it just happened because it had to. And that's, of course, it's had some pain points. It's not been perfect, but I also think it has created a lot of different opportunities to really rethink about how we deliver care and access to care. And that's, I think, of particular interest for those of us who live in rural and remote locations, like much of Saskatchewan, and certainly like where we are in the Yukon, where medical travel and patients often need to travel really far at often huge personal expense to access care. And what we found now with virtual care is there's a lot more opportunity to collaborate in entirely different ways and bring the specialist to the patient rather than the patient to the specialist, and for people in primary care to have this ability to connect with their patients in different modalities that often are more convenient for the patient or more desirable and less invasive on their time. And again, just create these more flexible models of care where the patient has also some control over where they are, where they receive the care, and what that looks like. So I think that's something that's going to provide a huge opportunity going forward. The work we've done on virtual care shows it's been, well received by providers and also by patients who largely are very satisfied with that care. And it just creates, I think, a different opportunity and to really rethink about what we do. And I think what's also interesting about that, which I've reflected on, is, one of the challenges I think with recruiting and retaining physicians in rural and remote communities is them feeling isolated, right? And not necessarily always supported. And virtual care is also a tool to support our doctors and nurses and other experts, health providers in these communities, right? You're a nurse practitioner in a health center, or you're a rural, like myself, you're a rural general pediatrician and you need some help. You can bring that person into the room virtually with you to see your patient, to talk to the patient and their family with you. You're learning at the same time. You feel supported. There's also been opportunities to join in continuing medical education around even an event like tonight, right? All of a sudden, anyone in the country or world can be joining us. So I feel there's these opportunities for connectedness, for learning, for sharing information, to supporting each other that are really particularly important for rural areas where you just don't always have those same opportunities. So I think that's something that we can scale and use that will be, I think, a positive. And I think the other thing we've seen is the system has had to be very nimble, right? It's incredible. Right. When you really think about what's been achieved in our hospitals, just having to move staff, leveraging different aspects of the hospital, being flexible about who is doing what, and reimagining some of those systems. And I think we've seen an incredible nimbleness of our staff and willingness to explore different things. And also, that recognition that by leveraging some of these things, we can get more efficient with how we use our hospitals. So like an example would be a lot of surgeries that used to be, some of, for example, knee and hip arthroplasty that always meant you were in hospital for a few days. Well, now we're seeing models where those patients can be rapidly discharged with good home care, some virtual follow-up, seeing things like remote patient monitoring that are, again, maybe allowing us to care for people in different environments, moving people into their homes more quickly and not having to have people stay as long as in our hospitals. So I think it's maybe challenged some of our assumptions about how things had to be. We've had to, out of necessity, try new things. We've realized, some of this works. And we can see some potential for some of those things as we move forward. And then I think the final thing I would say on that is I think, one of the beautiful things about healthcare is the teamwork, right? And I think if you talk to anyone in healthcare, often what they'll tell you is one of the things they enjoy the most is the other people that they get to work with. And I think this experience cemented how important teams are in healthcare, how much we can count on each other, rely on each other, but also, again, more opportunities to leverage people across the healthcare team and in different health professions to integrate the type of care we provide and to maybe get out of our silos a little bit and think differently about what care could look like. So I think it cemented that relationship we have with each other and perhaps challenged us to think a little bit differently about how these models of care could look going forward.
Yeah, we've got some great questions that are building up from participants. But before I go there, before I pivot, I wanted to ask you about social media.
Mm-hmm.
You've done just tremendous work in being the voice of reason, the voice of calm, the voice of truth, and really not only from a personal perspective, but on behalf of the organization and organized medicine as well. I wanted to ask you, yesterday you did a session for medical students here in Saskatchewan. What are any nuggets, words of advice in terms of what's gone well with social media, or advice that you might give us? So sometimes when we read it, it can be really discouraging. Other times it can be, kind of a source of information. We've
Yes.
had the good and the bad, but what's your advice? What's your observation?
Yeah, no, a great question. And I think it's like many things in life, right? There's pros and cons and there's kind of ways it works well and risks. So I would say, for me, it was a really rapid scaling up of my use of social media. I had, prior to being in this position, I'd only ever used social media to connect with friends and family in different locations. I'd never used it as an advocacy tool. And very rapidly, it became clear to me. It was actually sort of funny because the week before I became the president, while I was still the president-elect, and we were going into the Delta wave, I tweeted a thread about children and the Delta variant, and my concerns about going back to school. And it went totally viral, like 3 million views. And suddenly I was on the news, and it was very interesting, right? Because it was not planned that way. It just kind of got picked up but what was interesting for me is all of a sudden I was like, okay, this is interesting. This is a tool you can use to actually share your thoughts, your expertise, the questions you have with the public and create that opportunity for interaction and answering their questions. And from there, I really realized that I think it's a tool that we have to be using for a variety of reasons. One, I think we know many Canadians don't have a doctor. Over 5 million Canadians don't have a regular doctor. So for those Canadians, being able to connect with a medical person who's reliable, who's trustworthy, who's known to be that, and follow them and get information from them creates a bit of that relationship of a trusted healthcare professional they can look to for good information. And I think what's become clear through the pandemic is just how real the threat of misinformation and disinformation is now to our collective health. And we have had to battle that. But where does that live? That lives in social media. So if we are not in those spaces directly confronting those threats with equally, appealing sort of information sharing techniques, we're never going to win that battle. So I think it was a space that needed to be filled. And I found it was a really effective way to get your message out. I also think it's a really effective way to engage with colleagues. A lot of the physicians in Saskatchewan, I've gotten to know them through my work on social media. You start following each other and you start interacting and learning from each other. And then different opportunities come to perhaps meet these virtual meetings and hopefully in the future in person. So I think it's a way to engage, obviously in my role, part of what you're trying to do as the president is engage with the profession and hear from providers and making sure you know their experiences so you can represent them. So that was an amazing way to sort of take the pulse, I think, of the country and see what people were doing. And I think you also saw a lot of physicians supporting each other on social media by amplifying messages, by taking these different challenging issues and bringing attention to them. So it just became a way to really create that advocacy. The other thing, of course, that was important for me as a pediatrician was really using my platform to advocate around vaccination, not only for children, but also for adults. But, that was clearly to me critically important. And I felt like that was a space where I had some, expertise given my background. And I've had a lot of opportunities to use social media in that regard, whether it's tweeting about it, or I've done quite a few live events as well that have been online, which I love that because again, I'm like, if you're a parent and you maybe don't have a trusted doctor or other healthcare provider you can ask questions to, here's a panel of 4 pediatricians from across Canada answering your questions, and it fills that information void for people. So I think those are all the positives. And I think, and I think you have to be clear about how you want to use social media, right? I would say, like, for me, I really thought about what's the messages I'm going to be trying to send out, and try to kind of keep within certain things you're trying to amplify and do, so that it has a bit of a purpose. I think that's important. You have to be careful not to get drawn into the emotive aspect of social media. It can get kind of too emotional, where people are kind of attacking and blurting out at each other. I don't think that's particularly productive. And you also, of course, have to grow a bit of a thick skin, because there is a lot of trolling, a lot of attacks, a lot of online harassment. And I've certainly been on the receiving end of that, as have many physicians and other healthcare professionals, direct messages, calling you names, threatening you, this type of behavior, which is unfortunate, but you have to learn how to use it, right? Block people, mute people. Now the amount of that I experience is much less, because I've been able to get some of those people off my feeds, and it really cuts down on that. So I think you also have to not be afraid to curate your social media, to take control of it and use it to deliver the information that you think matters to the public. But I think it's been a really important part of informing Canadians. I think it's been a very important part of our advocacy at CMA, but I'm very proud of how many physicians, I think, have tried to leverage social media in a really positive way to keep the community informed and keep information in the hands of patients, and counter some of the narratives that were sometimes being delivered to the public. So I think it's a powerful tool. I don't think we can shy away from it. It's here, it's the future. And I think, given that, in my view, I think one of the biggest threats around the corner is this proliferation of misinformation. We've kind of got to fight fire with fire.
So it's not going away. And what we need to do is use it as effectively as a tool to be able to communicate, knowing full well there are trolls out there, and that is something that needs to be dealt with. And it takes it, we talk about leadership, to be able to move to doing the right thing and speaking truth to power in spite of trolls and others who would say otherwise. You've done a remarkable job of being able to rise above all of that. So beautiful pivot. And I'm going to jump around with some of these questions, if you forgive me. Dr. Dennis Kendall, who we know very well, writes, Dr. Smart, in spite of your specialization in pediatrics, I sense you understand and value the role that family docs play in our system. I sense that the historical role of family docs has been adversely impacted by the COVID pandemic. Do you concur? And if so, how can the CMA address this?
I think that's such an important question. And I would start by saying, absolutely, I have huge respect for family doctors. One of the wonderful things about my job as a pediatrician in the Yukon is I know the family doctors in our community very well. We work very collaboratively together, often sharing patients and knowledge, and lean on each other all the time. And it's wonderful to be part of that community. And I have a huge respect for the work that they do. I absolutely agree with Dennis's point. I think the pandemic, I think a few things. I think primary care has been really suffering in Canada for a long time for many reasons, largely because of the system for family doctors is not necessarily well supported, or the infrastructure they need to do their job. I think the pandemic has been very challenging for family physicians, and a bit of what I was talking about earlier, right? They feel this responsibility for their patients. They've had to pivot. They've largely been left out of a lot of the decisions by government, and even basic things like PPE to see their patients, vaccine rollout. They haven't always been included in those things. So they've really been, I think, left often sort of on their own. And there hasn't, there's been a lot of focus on the hospital, and sometimes we've forgotten about the community. And most of the care happens in the community. And again, who do you think's helping all these patients when they come out of the hospital, prevent them from getting into the hospital, trying to manage all their chronic issues? So I think a lot of times family doctors have felt ignored, not listened to, not necessarily considered in the decision making. And I think that's very frustrating. I think all of us are always up for challenges, but what's important is to feel respected and appreciated. And I think sometimes when that part of the relationship deteriorates, that's a real problem, because I think people will do a lot if they feel those two feelings from leaders, but if they don't, you sort of lose people. And I worry that that's a bit what's happening. I think, we're seeing a real challenge in primary care in terms of recruiting and retaining newer family doctors in longitudinal family medicine. So, of course, our healthcare model in Canada is predicated on this idea of all Canadians having a family doctor to provide that critical longitudinal care to help them navigate the healthcare system, to sort of, help people know when do they need a specialist or when don't they, what tests do they need, really like walk that path with patients to manage their health. And I think as we've gotten fewer and fewer people wanting to take on that role, and again, why that is, I think, is because of a lot of the structural issues that impact family doctors. They're essentially forced to run a small business while trying to provide care to patients, and they don't have a lot of control over a lot of those inputs, right? Rising rents, rising cost of staff,
Right.
increasing demands. And there they are trying to balance all that while still staying focused on the needs of their patients. Electronic medical records were supposed to make things better, but they've actually increased administrative time for physicians. We've seen increasing administrative workload too, as so many other failures in our system are downloaded onto doctors, right? Fill out this form, write this letter, tons of that. So, and for many family doctors, they have hours of paperwork. And we're not necessarily seeing our governments being willing to step up and help support some of this, or give them, other people to support them in their offices and clinics, like nurses, nurse practitioners, mental health experts, people, therapists, dietitians, to manage what is an aging and growingly complex population. So I think they're asked to do a ton. If you look at a place like where I live in the Yukon, they run the hospital, they provide the anesthetics, they work in the emergency department. I mean, these guys really do it all. And I think sometimes that's not fully understood or appreciated. And I think it's concerning that they don't always get the respect or support from government they need, because they are the foundation of our system. And the evidence is very clear that people that have a longitudinal primary care provider have better health, they have fewer complications, their chronic diseases are better managed, and they utilize acute care resources less, and they're saving costs in the long term. But it's not as sexy as, interventional radiology or heart transplant. So sometimes it doesn't, I don't think, get the attention and respect it deserves. And that worries me.
Yeah, let's talk a bit about that attraction of the kind of sexy stuff in healthcare. Beds, the equipment, the diagnostic capacity. So Denise Worker asks, how will you address the current advocacy efforts of physicians to increase hospital beds rather than investing upstream and reducing inequities?
Yeah, great question. I think, and I think what's important in all of these questions, I think, is to realize it doesn't necessarily need to be an either or. I think sometimes we get a little bit cornered into these things that we feel like we can only do one or the other. And I think what we've seen in the pandemic is both those things you're asking about are very important. We have one of the lowest number of hospital beds per capita in Canada of comparable countries. And we've seen what that's meant when we had to scale up on our acute side to manage people with COVID. What it's meant is everything else ground to a halt. So now we have hundreds of thousands of people who have backlogged surgeries, diagnostic imaging, cancer screenings fallen by 35%. We are going to pay the price for this in the long term. There are going to be many people, and there already has been, as I mentioned earlier, that have lost their lives or are going to present with more advanced disease and have more complications because they couldn't get those things they needed to address their health. And behind all those numbers that we talk about with backlogs are patients who are suffering, right? They're people with chronic pain, issues with mobility, stress, perhaps waiting, wondering, is my cancer growing while I'm waiting for this procedure? So these are real people that are impacted. So I think there's no question we need more of that capacity. But equally true is, this is about, we're talking about the disease system, where we're talking with what I was just saying. What you're also asking about is, how do we get people healthy? And how do we create health in our society? And that is not done by the medical system. That is done by those upstream issues. And those are critically important. And that, like, for me as a pediatrician, particularly with what I see in the work I do in the Yukon, I can tell you, I think that's so important and so interesting to me as a pediatrician, because so often what I find when you're at these tables is they're largely people who work with adults, and they're largely people whose focus is on adult health. And so often they don't have that lens of, when you look at, for example, the opioid crisis, I bet you behind 99% of those people is a history of childhood trauma, right? There's a reason why people end up using drugs. There's a reason why people end up homeless. There's a reason, and that reason is often adverse childhood events and trauma that set this trajectory that they're on, that ends up with these horrible health outcomes. So how do we change that, right? We've got to be investing in families, in women, making sure that people are supported through their pregnancies, that any health issues they have are being addressed, that their mental health is being addressed, that they're given the parenting skills and the basic things, safe housing, access to nutrition, positive things to do in the environment, learning how to interact with their child in a way to improve their early development so that their brains have their full capacity to be ready to go to school and learn, and the child is in a safe, nurturing environment to develop their sense of self. I mean, this is how we create healthy people. But that is not something that we invest heavily in. And then instead, we're downstream trying to solve these problems later on. And it would have been much easier to have addressed it up front. So I really think we have to do two things. We have to make sure we have a healthcare system that's there to treat disease, but we also have to rethink about what we mean by health and understand that health is created through addressing things like social determinants, through having strong programs for our families, strong emphasis on children in their early development and the environments they find themselves in. And I think that's how we're going to see that broader change and less need for the healthcare system down the road.
It's excellent. Tasker asks a great question. How can the trust between healthcare providers and experts and governments be rebuilt?
Yes, a great question. I really believe, like in most things, humans are kind of the same. Like we have a basic psychology that applies in most of the environments that we're in, right? And I think, what that is we have a need to trust the people around us, to have rapport and to have relationships with each other. And I think it's important to understand we don't always have to agree, but we have to be respectful, and we have to be willing to listen to what people are saying. And I do worry that, again, in this period where we've been more isolated from one another and some of our communication has kind of come down to, tweets back and forth, or, these political arguments where people are yelling at each other in our various legislatures across the country, that we've lost a little bit the art of dialogue and compromise and listening, right? Actually hearing what people are trying to say. And I think it's really important for politicians to realize, the people who know about healthcare are the healthcare workers who provide healthcare, not just doctors, nurses, therapists, social workers, dietitians, pharmacists. There's many of us. And I think it's really important that governments deeply listen to what those people are trying to tell them, because they have that lived experience. They're the experts in that. They're not maybe the experts in administration or, other things like that. That's why I think this idea of the physician administrative dyad is so important, because you bring together essential skills, right? But you need both skills. Neither is more important, but together, that's the magic, right? And I think if that togetherness can happen from a place of deep respect and listening, where we really want to understand each other's problems and really be committed to the outcome, which needs to be a system that serves Canadians, we keep that as our goal, then we can hear what each other's trying to say, recognize we're all going to have to make compromises along the way, and that's okay. It can't be a zero-sum game, but I think we need to reestablish those relationships with each other. I think without that, you're never going to really get where we need to be.
Thank you for that. Michael Sokoluk asks, I would love to know what Dr. Smart thinks needs to happen to combat misinformation and disinformation.
Oh, yeah, that's such a great question. I think it's fascinating. As we've gotten deeper into this issue with misinformation, I think we're also seeing more research about what drives people towards misinformation, what makes it so compelling to some people.
Right.
And I think that's, again, it's kind of like that question of, investing upstream or the hospital. Like it's sort of similar. There's reasons why people are drawn to that, and they're often upstream reasons. So what is that? Disconnectedness, right? Not feeling part of a social fabric that drives people towards sort of extreme theories and things. What happens, right? They land there, they find a home, people that accept them, people that make them feel good, people that listen to them. And suddenly that's a very appealing community to be part of. So I think we have to understand what's driving that. I think there's been a lot of people that have felt, obviously the pandemic has been incredibly stressful. People have lost their jobs. They're in huge economic distress. They've maybe had their own health issues. They've lost loved ones, or perhaps they've just, over these different opinions on things, they've lost relationships that matter to them. And I think that's made us perhaps, again, more polarized, and there's been so much passion on both sides of this. And I know I felt that myself. It can be, again, it can get in between. And I think the problem is the more we polarize, the less we're listening to each other. we create a void where misinformation can fill to make those people that choose to believe that feel connected. So I think we have to sort of understand what leads to people to feel alienated or on the margins of society and how these things can be desirable. So I think that's one piece. I think the other thing is we have to realize that the groups that promote misinformation are highly organized, skilled, and sophisticated. And they have learned to harvest the power of celebrity, which is, I think, now a huge also part of our culture, to promote these ideas. So I just take the example of pediatric childhood vaccines. You know, you've got Candace Owen, a right-wing pundit in the United States, who's decided to personally research childhood vaccines, and she's out there now, 3 million followers on Twitter, promoting her vision that we're over-vaccinated. You know, what do you know about this? Like, arguably nothing. But you've been able to put yourself out there to the world, and you have this audience that amplifies your views very effectively because there is this sort of magic of celebrity. So I think we also have to understand that phenomenon, and we have to make sure that we are creating health communicators and science communicators and finding ways to combat that information on that same level, right? We've got to get out there with the better videos, you know, the rock star type people to share our message too, right? You can't kind of be sitting there with your bad lighting and your half Zoom call with your head half in it, trying to tell people things when they've got, you know, the air band and the rockets going off and the Super Bowl show to share their piece of information. So I think we have to really get more serious about how we communicate, upping the game, and really creating high standards for health communication to share these critical messages with the public. So I think it's understanding where people are coming from, trying to pull them into the tent with compassion, but then also realizing, like, this is a bit of a battle, and we got to come into the battle properly equipped. And that means we're going to have to up our game beyond what we're used to doing, and live in some of these spaces to take some of this on.
I wanted to ask you, because we certainly noticed it in the early days of the pandemic, as epi curves and data is being talked about more and more. It was very interesting because it was being used in everyday discourse with the public, whereas in the past, pre-pandemic, it would have been very rare to show an epidemiological curve. The use of data, the use of even big data in healthcare, where do you see it moving as we move out of the pandemic? How can we maximize the benefit for all kinds of data, including big data in healthcare? And this question comes from Sharif.
Yeah, great question. And I think, you know, we've seen the pros and cons of that. Of course, you know, you start sharing data and then everyone's analyzing the data themselves. It's like, okay, this is interesting. I sort of feel like, do people go build bridges on the weekend on their own because they looked at YouTube? Probably not, but we're doing that with our science interpretation. Yeah, so that,
I found a video on how to do it.
Yeah,
so I'm pretty sure I know how.
So I think that's kind of interesting. However, that being said, I think we also saw, you know, especially I think when things could be visually represented, I think we also saw the power of that, right? Like trying to say to people, there's exponential growth. Well, what does that really mean? But if I show you a graph with a line going vertical, and I'm like, yesterday it was 10, now there's 100, tomorrow there's 1,000, people are like, oh, okay. So I think, you know, using data, visual representation, some of these things to actually convey complex ideas is actually very powerful, because I think a lot of the language we use doesn't always mean the same things to people. You know, I always remember when I built a house and the contractor would talk to me and I like literally didn't understand every third word he said. And I'm like, oh, this is how patients feel. Like it's a whole nother language. So I think we have to be mindful of that. And I think using things like showing people data but doing it in a way that's accessible, I think is important. And I think we also have to realize that people learn in different ways, right? Some people may hear information, it may make sense. Other people, that visual representation may make sense. I think by sharing data with the public, again, I think people are wanting transparency, they're wanting information. It just gives people one more thing they can access and hopefully understand. And I think it's ways to convey, you know, big directions, big ideas in a way that's perhaps more tangible. So I think there's a lot of opportunities there. And I think we saw some very effective use of visual representations of epi concepts and data itself throughout the pandemic. And again, we saw it really sort of democratized, right? Like you think early on that Johns Hopkins site, they were showing all the dots of what was happening where, very, you know, and even the the Health Canada website, where you can go and find all sorts of statistics you can run about what exactly is happening places. It's really allowed people to have access to information that they wouldn't have really had before. So I think that's going to be interesting. I think people are wanting information, and I think what we have to be mindful of is, are we putting it out there in a way that can be consumed in a meaningful way? And that's, of course, always the risk is sometimes that's challenging. But I think if we've learned anything from the pandemic, it's that we've got to dial up our health communication.
Now, one of the things, and I don't want to be too pandemic focused, but it's hard not to be. What we saw in those early days and throughout the pandemic were outbreaks in long-term care. So
Yes.
residential long-term care, seniors care, housing, and homes were sites that lend themselves to kind of outbreaks. There's congregated living settings. So can you speak specifically to the new national long-term care standards, in particular its outcome and resident-centered care focus, and how we can ensure the government does its part in regulating quality residential care for some of the most vulnerable citizens? This question comes from my colleague, Ramona.
Yeah, very important question. And absolutely, as you well stated, the early days of the pandemic, but arguably even now, we saw people in long-term care so disproportionately impacted, and of course just so much loss of life there, and also just horrific conditions for people that were just often left and abandoned during this period. It was horrible. And one of the things the CMA has been vocally advocating about is this idea of national standards for long-term care. So again, I think this is another example of a problem of a major expenditure of healthcare dollars and a major need for Canadians that's outside the healthcare system, right? So long-term care is not under the umbrella of universal healthcare. We know some long-term care is publicly provided, some of it's privately provided, and it was very clear, especially in Ontario, that the outcomes in the private facilities were much worse than the public facilities. So there was a difference there in terms of what happened. And one of the things that we were really encouraging was that we've been talking a lot about federal leadership on several aspects of health, but particularly in long-term care, to have some basic standards that long-term care facilities had to rise up to ensure dignity for people that are aging. I think alongside that, the other thing that we've learned at the CMA through our work around with aging Canadians around their desires is the other big message is people want choices about where to age. People want options, and people want more options to age in place. And again, this I think comes back to that issue of what's available for people. What does home care look like in the community? How can people get support to stay in their homes? How do we ensure that people are able to age with dignity in the location that they want to? So I think all of these things are a really important part of those conversations. I think that what the other part of your question around accountability is really critical. I think it's not only an issue in long-term care needing that accountability around the quality of care that's provided and what people can expect, but throughout our healthcare system, we struggle with accountability. We don't use the data that we have. We don't have data on many things, and there isn't a lot of accountability in general. And I hope as we get better at accessing the data that we have and we see more interoperability between things like electronic medical records, that in general, we can drive a higher level of accountability in our system, because I think that's of critical importance. And we need to make sure that those investments that are coming from the public dollars are having the outcomes that are needed. And I think the other really sad part of what happened in long-term care, and another thing that maybe had to switch our thinking a little bit, was the exclusion of so many carers from that environment. So family members who were not just visitors, it's this, again, the importance of language, right? They're not visitors. They're often care providers for people in that home and in those homes, and how often those folks were shut out of accessing their loved one, and just how awful that must have been for so many elderly people who were just isolated for so long because we couldn't figure out how to navigate that. And the impact of that, I think, is also substantial. So again, I think there needs to be a rethink around some of these issues, and we need to redefine sort of what role people play, because there is a lot of unpaid work in the healthcare system provided by family, and that needs to be valued.
So we as a school have this great privilege of working with health leaders right across Canada. And we were working with York Care Centre in New Brunswick. And what they did was they actually certified all their family caregivers, trained them up in infection control practices, put them on the team. and didn't block them from coming in.
Yeah.
So those types of innovative approaches where, yes, we understand in the short term, there may have to be making some decisions, but those decisions have implications, particularly in a crisis that lasts this long, that endures.
Yes.
So I want to thank you for that. I wanted to just kind of turn to your vision for healthcare. Let's start, first of all, with the Yukon and Whitehorse. You had mentioned in your earlier remarks that you presented a plan to government. You drew it up, you presented it, and you got carte blanche support for it. And when we think about the Yukon and the beautiful city of Whitehorse and the beautiful territory of Yukon, some of the challenges with sheer geography of a territorial delivery, but also some of the benefits. You can almost, everyone, right? You can meet everyone. Stephen Samus, the deputy minister, you can walk into his office, you can have a discussion. So our things, and this really comes from my colleague, Cheryl Camillo, would you have been able to get that kind of a support in a province, like a jurisdiction, with these more sluggish, larger population systems and bureaucracies? Or is there something special about what you've got going on up in the Yukon?
Yeah, I would say the answer to that is no. I would have been much more complicated. I think for many reasons, right? Yeah. First of all, the scale of what we're talking about was very different, right? It's a territory, 45,000 people. And there really what pediatrics was at that time was 6 pediatricians who each came 4 days a month and ran a visiting clinic. So the amount of service provision that existed was very small, right? There wasn't, a children's hospital and all the subspecialty services and, the volume. It's essentially like a town that is a territory. So I think the scale very different. So I think it'd be much harder. And again, there was sort of no real pre-existing invested interests that needed to be navigated either, because that can be a big barrier to change, right? We know people tend to want to protect their piece of the pie. There's a bit of a bias towards the status quo if it's working for you. And sometimes even just navigating those relationships amongst ourselves can be a real barrier to change. So I think that I was fortunate in that the scale was small. And then I think, Dan, like you said very clear, it's true. It was not hard to find out who was who and who the different leaders were. And then, like I mentioned before, I really believe that relationships are really powerful in driving change. And I literally was able to find out who people were and go meet them. Okay, you're the head of student support services. I want to talk to you about how can we get pediatricians in the schools, right? Okay, you're the head of community nursing. How can we do outreach clinics to our community health centers? You're the head of Council of Yukon First Nations. We want to partner with First Nations. How can we work with you? What would that look like to you? What do you want us to do? And really just sit down around the table and hash these things out. And that's really what we did, built those relationships. And that's, I think, why it worked.
I'd like to think that that's a skill set that you took from Saskatchewan.
100%.
Is that true?
I think it is true. I think Saskatchewan is about community, right? It's people from Saskatchewan, they care about each other. It's a community-minded place. There is a lot of know your neighbor. I mean, my parents used to always say that to me, you got to go look people in the eyes, shake their hand, talk to them. Yeah. So you sort of learned that. And I think, at that point in my career, I'd been in medicine for a long time already. And I think I saw that. I saw that the successes that I'd had or when things had worked is when people trusted me, when we had a relationship, the importance of asking questions and listening. And often, I find that often people want the same thing, but sometimes it just takes someone to lead that direction, right? Like it's not that people disagree. It's just no one maybe wants to step into making it happen. And I think for me, that's what I love doing, right? I like being the builder, the change maker, getting in there and getting everyone kind of moving in the same direction. I enjoy that. And I think for some people, they want to be on the team, but they maybe don't want to be the person that has to sort of create the direction. So I think it's also about leveraging different people's skills, right? We all bring different things to the table. And I think some of finding opportunities for yourself is understanding clearly your own skill set, what drives you, what your purpose is, and taking opportunities that align with those things and just sort of going for it.
I loved your comment about team. And if anything, as we specialize and subspecialize, it becomes even more important that we form teams and that we coordinate and learn from each other. Can you speak a bit about your vision with respect to teams?
Yeah, for sure. I think That's so important. And again, I think for me, you know, my first part of my medical career was in the emergency department. Well, I mean, nowhere do you need more of a team. I mean, in a different scale, obviously, because it's a team usually focused on a patient, but you have the sickest patients, the most undifferentiated patients come in, and very rapidly a group of people descends in that scenario and has to rapidly communicate and work together to save that person's life. And you learn, you know, very quickly about the importance of being able to rely on each other, count on each other, respect each other, welcome all voices, asking people to give you feedback, step up, question you if you're missing something, right? These are all the things we do in medical simulation in these high stakes situations. And you learn to want to draw that out. But those same principles, I think, apply in any context with team. It's the same idea, right? The basic assumption, everyone here is a smart person doing their best. You know, when we disagree, it's not about the person or who they are, it's about the idea. Welcoming people to step up, ask questions, own that space, and really learn to rely on each other and ask each other what's working for you, what's not, what do you think, what are we missing here? And I think those same concepts really apply to any situation and any complex situation. If you can think about it like that, you can bring out the best in people. I think give people credit, move away from, I think, the risk, which is making assumptions about who a person is at their core because of something they've said or done or a decision they've made. And learn the importance of sort of finding that shared goal and direction and what you can agree on, and then how do you move towards that collectively. So I think the beauty of healthcare is the team. That's what's fun. There's so much depth of knowledge and expertise across different areas of health, and I know for myself, I've learned so much and benefited so much from all the different people I've been able to work with. And you take pieces from people, right? You incorporate it into what you do and how you work. And I think if you can keep doing that, you can keep building that. So one of the reasons I'm so grateful I ended up in healthcare is because of all the amazing people I've met along the way. And I think that's what keeps you invigorated. And I think that's also what's hard for doctors or any provider who is working in isolation. You don't get those touch points to fuel you up again, right? And I think feeling like you're part of something bigger goes a long way just to fueling your own psyche.
Wow, talk about time flying by. I have time to ask one more question. How's that? I feel like our armchair discussion should, go on and on, but I know your time is precious. Denise asks a very important question. Denise Worker, I've been struck that there has been no meaningful societal dialogue about what are acceptable deaths. Reported rates of deaths in Canada are higher than the peak rates of deaths during Delta wave, but no one is talking about this. Has the CMA considered initiating this dialogue?
It's a great question, and an important one. And I think you're absolutely right. It's true. Like you say, what is it like that? It's a really profound question when you think about it. Like, what is an acceptable death? Like, we know, of course, people die, that happens, but we know many people die prematurely or from things that could have been prevented or in context, things that didn't need to happen. And what are we going to do about that? And I think you're right in that right now, it's not happening with respect to COVID, but even in other aspects of healthcare, it's not happening perhaps with the same dramatic nature that it felt like at other phases of the pandemic when our hospitals were overwhelmed. We're hearing about it all the time. I think it's like, unfortunately, like a lot of things in the world, people get numb a bit to things over time. And I think there's been a strong desire at this stage of the pandemic to kind of act like it's all finished with. We're definitely seeing that, I think, from our governments, the messaging that we're hearing. There's been this real just kind of we're pulling away and this feeling of we're moving on. And I think you're right. I think because of that, there hasn't been as much perhaps desire to really dig into exactly what's happening and sharing some of that information. I would say, right now that isn't something that we've talked about at the CMA specifically, but I think that's a really important question, and it is perhaps something that we do need to be looking at and amplifying, because I think it is a challenging time right now. I think we're at this sort of strange inflection point where it's like people are kind of marching on, but yet we're probably also entering another wave, and there's this sort of again, because we don't seem to have that same cohesiveness that we had earlier stages of the pandemic, it's getting harder and harder to kind of bring people along with the reality of what's going on. So, I thank you for bringing that up. Yeah, it's something that I need to think about.
It's over doesn't
That's
mean
right.
Yeah.
No, and it's not over. That's very obvious. But how much of the dialogue it's dominating on its own, I think, is lessening. And I appreciate you bringing that up. And I think it's important that people keep bringing these things forward and asking these questions.
Well, this has been a breath of fresh air. I really, really appreciate the chance to chat. And I got to tell you, and this is a message to your parents. Thank you for raising such a smart, dedicated health leader. And to be so personable and an ability to just interact, it feels so natural. So I want to thank you for that and thank your parents. They should be proud, very proud. I'm going to turn back to Jennifer for some last words. So thank you very much, Dr. Smart. Really appreciate your time.
Thank you,
Yes,
Dan, and to everyone for having me. It's been fantastic. So thank you so much.
Great.
Well, I thoroughly enjoyed this evening. Thank you so much, Dr. Smart and Dan, for such an interesting and detailed discussion on where we think healthcare is and where we think it's going. I think what stood out most for me from today's presentation was that challenges and opportunities are best navigated by amplifying the connections and relationships throughout our healthcare system, and just to keep in mind respect and collaboration with all levels and all people. And I think with that in mind, if we go forward with that, we can't do much wrong. Before I conclude the 4th annual Houston Lecture, I'm pleased to remind you that this lecture was recorded and will be posted on the JSGS website once it's been edited. For more information on upcoming JSGS lectures or to learn more from our programs, visit us online at www.schoolofpublicpolicy.sk.ca. And thank you once again for tonight's speakers, Dr. Smart, Dan Florazon, Lillian Berdahl, and the members of the JSGS Houston Committee, who work really hard to select excellent speakers like Dr. Smart and topics for the series, and also, of course, the Houston family for making this event possible. Last but not least, thank you all for coming and for listening and learning with me, and we hope that you found the conversation relevant and interesting. Thank you, and good night.
And thank you, Jennifer. Hey, the future is bright. We're so lucky to have you as a student. Thank you.